So this is a totally different trial. It's about mantle cell lymphoma patients. This is a phase 3 trial that enrolled 300 patients, younger mantle cell lymphoma patients treated with high-dose chemoimmunotherapy and followed by an autologous transplantation, and then a randomization between lenalidomide maintenance versus observation. We already demonstrated from this trial that TP53 mutations and deletions, as well as KMT2D mutations, confer a dismal prognosis in terms of both progression-free and overall survival. In the updated here presented in the Lugano meeting, we analyzed the CD19 selected cells from bone marrow, baseline cells, for copy number aberrations. We were able to identify about 350 copy number aberrations from 164 patients for whom we have available tumoral DNA, basal DNA for analysis. So we were able to identify 351 copy number aberrations. We performed univariate analysis in order to see whether some of these aberrations have an impact on progression-free survival. We identified 10 of these aberrations impacting on the progression-free survival, and after multivariate analysis, only 4 remain significant for PFS. We excluded the deletion, the classical deletion of TP53, because we already know about its relevance, and we identified the KMT2D deletion in 30 patients, deletions of chromosome 22, the deletion, a small deletion in the chromosome 9, and also in a few patients a loss of heterozygosis in chromosome 17. So this signature of 4 copy number variations was able to stratify patients for progression-free survival and for an dismal progression-free survival and overall survival as well. So we try to incorporate this copy number variation signature into a prognostic model that we already published. That was the MIPI-G, the MIPI genetic. MIPI genetic comprises KMT2D mutations, TP53 aberrations, and the MIPI-C high-risk class. So we introduce also the 4 copy number alterations, and after the multivariate analysis, only the genetic variables, so the copy number variation, TP53 aberrations, and KMT2D mutations, remain significant for progression-free and overall survival. Therefore, we build up a new prognostic model that we named MIPI-GO, that means MIPI genetics only, in which there is no more contribution of the MIPI-C, so the classical clinical prognostic index, because it was no more significant after multivariate analysis. With this MIPI-GO, we were able to stratify 150 patients in high risk, intermediate risk, and low risk patients. And an advantage of this MIPI-GO respect to the MIPI-G was that we were able to classify a double number of patients in the high-risk class. So the high-risk class represented about 14% of the entire series. So the MIPI-GO, the new model, was able to reclassify the risk profile of all the patients with respect to the MIPI-G, both in the low risk, in the intermediate risk, and in the high risk, and also provided a total reclassification of patients if compared to the classical clinical MIPI prognostic index. So we propose this new new genetics-only prognostic model, the MIPI-GO, to stratify patients, to identify by only biological predictors, to stratify patients, to identify high risk cases that probably will not respond to conventional chemoimmunotherapy, even given at high doses. And so that probably might benefit from inclusion in frontline prospective clinical trials, or in the clinical practice, maybe to something different from the autologous transplantation, something like new molecules integrated in the first line, or a CAR-T based protocol.